My present. How's it? Are you able to see everything, or how does it look
Yes,
on
we
your
can
side?
see. Yes, yes, it looks good. And
Okay.
it's full screen now and everything is perfect.
All right. Let me go to. Okay.
Okay, so today we have Dr. Naveenraj Solomon from California, USA. We'll be talking about unresectable metastatic disease in colorectal cancer, the management of the asymptomatic primary site. Thank you, Dr. Naveenraj, for joining us today, and the floor is yours.
Thank you. The pleasure is mine. I appreciate the opportunity to be able to talk about this topic, and appreciate the opportunity. This is also my first lecture that I've been given in an international setting, so thank you for this. And hope to continue educating and talking and collaborating with groups all over the world. And I think that's one thing the pandemic has shown, that Zoom has made our world smaller, so we can connect on a much more personal level. I think I recall with Zoom, we even had lectures from top professors in Memorial, Sloan Kettering, and Johns Hopkins on topics, and just to bring those professors out to California, costs money, but with Zoom, we've been able to still get the education and everything. So appreciate this opportunity. So I'm going to talk about the management of the asymptomatic primary site, specifically, in the setting of unresectable metastatic disease with colorectal cancer. So it's still a topic, an area of controversy. Hopefully we'll have some clarity, but it's kind of an ongoing clarity process that's happened over the years. So I'm a surgical oncologist at Loma Linda, just some bit of information from me. So I trained at Loma Linda University for my medical school and residency. I did my fellowship at University of Miami. And I came back here to Loma Linda. So I serve as the vice chair of the Department of Surgery. And I practice here in surgical oncology. And so a lot of my practice tends to be hepatobiliary, pancreas-based, breast, soft tissue sarcomas. I do some colon, but we also have colorectal surgeons as well. So I don't have anything to disclose. So objectives, ideally want to look at some statistics with colorectal cancer. I do want to touch a little bit on systemic treatment. And then we'll go into the depth of management of synchronous disease, and what do we do with the primary. And then at the end, I'll kind of give you my feelings of how do we manage this, because there's just so much data out there. And I'll kind of give just I've made up a little algorithm of how I would approach some of these patients as well. So colorectal cancer is the third leading most common cancer death. It's the third leading most common cancer globally. And it's the second leading cause of cancer-related deaths globally. So most recent numbers that I saw were 930,000 deaths worldwide. And about 20 to 25% of these patients present with synchronous stage 4 disease. And so this includes, peritoneal disease, liver disease, lung disease, extrahepatic disease. So, and what we know is that about 25% of the patients with stage 1 to 3 will develop distant disease. So the society, not the society, but the surgical oncology clinics of North America, they worked on a bit of an algorithm in one of their more recent books that they put out in 2022, looking at colon cancer with synchronous metastasis. And if you look kind of one of the first big things that we think about in managing this is having a multidisciplinary discussion, so talking with our medical oncology groups about how do we manage this specific patient? What regimens do we have as far as treatment? We use this resectable, is the metastatic disease resectable or unresectable? And so this is an example of an algorithm that is, I think, kind of the thought process of many of us have when we look at this disease, and where does surgery fit into this whole practice of taking care of this group of patients. And I'll touch just on a couple of things, and then at the end we'll go more into the unresectable and management of the asymptomatic primary. So in management of synchronous disease, treatment with curative intent can take place in about 20 to 25% of patients. We know as far as where does this disease spread more often, or where does it show up more often, the liver is the most common. And currently we have survival data of 5-year survival rates of 24 to 58% of these patients. And this is just sort of all comers. The lung is the second most common spot, as we know. 5-year survival rates tend to be at about 68%. And I have a brief slide on this, but most of this data is mainly from retrospective data. Peritoneal carcinomatosis, about 5 to 10% of patients present with peritoneal carcinomatosis and disease in other sites. I'm not going to focus on HIPEC or cytoreductive surgery. That's a much more controversial, complex topic way outside of this. But we know that this group of patients does exist. And so, I guess the definition of unresectable has sort of changed in this era. But again, the treatment for those groups of patients is different. And there's been, several studies looking at whether we should be doing HIPEC, and they only really just need cytoreduction. But anyways, moving forward. So resectable synchronous disease. So when we think of liver metastasis, and a lot of this is just sort of a summary of what is out there as far as the National Cancer Comprehensive Network guidelines with NCCN. Many surgeons can look at this as a surgery first approach. The thought process being you avoid liver toxicity by giving them chemo up front, by not giving them chemo up front and going straight to surgery. But then you're also addressing the liver and you're addressing the primary site. There's this thought by if you do surgery first, you can eliminate metastatic cell tumor shedding of the primary site. And also that if you do surgery first, especially taking out the primary, when they're on chemotherapy, you can prevent any complication that takes place. So that's been kind of the thought process of surgery first approach. But more common in our practice, in my practice here at Loma Linda, we tend to go in synchronous disease with a chemo first approach. Several different reasons that tend to be with looking at elimination of microscopic metastatic disease. You can cytoreductively reduce this by giving chemo. Some less bulky disease bulky disease becoming less bulky. You can convert unresectable to resectable, or even borderline resectable to resectable. And then one of the issues that happens is, if we operate first, oftentimes these patients may get a complication from surgery. And if they get a complication from surgery, our medical oncologists are going to be delayed in when they can start chemo. And so there is ideas that if we give chemo first, then we can at least treat the systemic aspect of their disease, and then do surgery later. And this also allows us to do biologic testing of the cancer. By giving chemo, does this shrink? Is this cancer actually, is it responding to chemotherapy? Lung metastasis, again, most of the recommendations on how do we manage lung metastasis has been retrospective series. There's only been one study that I saw that was a randomized study. They stopped it because they couldn't get enough patients enrolled. And in the data that they had, they didn't see any difference in patients having, resection of the primary and resection of the lung metastasis. So when we look at unresectable synchronous disease, so 80% of patients, this looks at about 80% of the patients. So some of the patients who have synchronous disease, we can put them on that tract of surgery. But then the large portion of many of these patients, they may not be on the surgery first pathway. And so this is where systemic therapy, is the mainstay of treatment. And so we do know in the last decade, we've had improvements in the different chemotherapy agents that medical oncologists have been able to utilize. So just to kind of give a quick, I have a few slides on this. Most chemo we know is 5-FU based. We have additional now targeted therapy based on the molecular tumor markers. So, we are testing these patients for RAS, NRAS, KRAS, BRAF. We look at MSI and MMR status, so we know that this helps us in ruling out Lynch syndrome. And there's even more recent data with MSI high patients of additional treatments that can be used. HER2 status, we only really look at this if we have wild type on the RAS and BRAF, but these are fairly rare mutations. So when we look at patients that have wild type KRAS, NRAS, and BRAF, this is a good portion of most of these patients. We know that they'll benefit from either cetuximab. Panitumumab is another drug for EGFR inhibition. But even more, the more recent literature looks at left-sided tumors versus right-sided cancers. And I know as surgeons, we want to kind of get a sense of what is our oncologist going to do when we see these patients, but understanding that left-sided tumors may benefit from one chemotherapy versus another chemotherapy drug. Whether this is because left-sided cancers may do better versus right-sided, I think is fully left to be elucidated, but we know that the regimens for both sides and wild type can differ. These are some of the different trials that have been out there that have used to support this management algorithm with chemo in the sense of 5-FU based with cetuximab or panitumumab. As you can see, one's the Crystal, the Prime, the Fire3. This has all been within the last decade or so that have come out. In KRAS and NRAS, when we have mutations, there's no real role that we have seen for targeted therapy. And now a little bit more recently in patients that have BRAF mutation and the RAS status is wild type, what they've seen is that if you combine 5-FU based, you can only use the EGFR, so you can use cetuximab in the setting where the BRAF has specific mutations. And so there was the Beacon trial that looked at this. And what they found that if you combine cetuximab with these other two drugs, ecorifanib and binimetinib, I believe, is a TKI inhibitor. Ecorifanib is a BRAF specific inhibitor. This may actually be a MEK inhibitor. But these are the triplet and doublet therapies that they put patients on with this specific mutation to get a better response. And this is important for us when we see these patients. We may see them with these big tumors, and we want to get a sense of, well, do I want to dive in and operate on this right now? Or can I send this then to the medical oncologist and they can look at this and they can treat, and then, depending how they respond, can I operate on them later? And then HER2 mutated tumors, this is a very smaller group. First line tends to be FOLFOX or FOLFIRI still. Second line, if they fail that, they'll use trastuzumab, or even now there's data for pertuzumab and lapatinib, which is a TKI inhibitor, I believe. So more recently, the Keynote 177 trial came out this year. So this looked at specifically MSI high and MMR deficient patients. So these are basically Lynch syndrome patients. And pertuzumab is considered first line now in this group of patients. And the study showed progression-free survival 16.5 months on immunotherapy. And I've actually had one patient with this. I had a very young female in her 30s, and she had a very large tumor. She was not metastatic. We thought she might be metastatic, but she had a very large tumor in her abdomen, had a bowel obstruction, had an ostomy, and we put her on pembrolizumab, and the tumor shrank significantly. And when I operated on her, there was no tumor left. She had a complete pathologic response. And so we took out her entire colon and then reconnected her back, the small bowel to the rectum. And she's been doing very well since the operation. But this tells us, the systemic therapy part of this cancer management is very helpful to us as surgeons. So let's look at now a little bit more as we dive, now that we have a little bit more understanding and kind of reminding ourselves of the systemic options, what do we do when we're looking at the unresectable disease and the primary tumor? So we know when there's symptomatic tumor, when there's bleeding, obstruction, perforation, these are the three biggest ones. Pain can factor into this as well, but oftentimes that pain will get better from these tumors if they start on systemic treatment. But bleeding, so some of the mainstays with bleeding, if they're bleeding and we're having to transfuse them often, so surgical resection does play a role in bleeding. Chemoradiotherapy, so in situations where it's a rectal cancer, where it's not a very easy operation to just go in and out, these are patients where we may have to use chemoradiation in this setting for symptoms. In obstruction, so either resection or bypassing or putting a stent. And then obviously we know with perforation, these patients are very sick. Sometimes we have the interventional radiologist here put a drain, or the other option, we just take them to surgery and, take out the perforated tumor and then, have to either reconnect or go back later to do additional operations. So just to look at, where from a standpoint of obstruction, options for surgical resection, most of what I've seen and what we've done as far as when the patient's obstructed is we generally will resect these in the setting of unresectable metastatic disease. Depending on the burden of disease, we'll do surgery. And so, the options are very broad when it comes to doing colon operation. It's rectal cancer, which is always a little bit more difficult because as it's much more complex surgery. So I think more often in rectal cancers, we tend to divert versus resect, or we put a endoscopic stent. So stenting, this is just a couple of imaging of how the gastroenterologist can do stenting here. These are self-expandable endoluminal stents. I have not generally used this in rectal cancer because, especially on a low-lying rectal cancer, because it tends to be more painful and it just causes more problems than making the patient feel better. So more often in higher rectal cancers and other parts of the colon, if they are a candidate for a stent, if they're too high risk to operate on, stenting is another good option for this. These are what these stents look like. As you can see on the top right picture, this is a splenic flexure tumor where they're placing a stent, endoluminal stent, to open that up. And endoscopically, this is what it looks like as well. So on the asymptomatic primary, those are the ones with symptoms. Well, how should we take care of this? Do we have to operate? Is there true benefit for operating on these patients? As surgeons, as you know, we all love to operate, but it comes down to how is the operation in someone who has no symptoms going to help? So this has been elucidated by at least taking patients and placing them on numerous studies. So what are some of the pros if we operate on the asymptomatic? So some consider the pros being prevention of complications when they go on chemo. And there are complications. We all know this happens when patients go on chemotherapy with the colon. There is a potential for overall survival benefit. And this is where I'll talk about the literature on this. And then there are some cons because you can potentially delay systemic treatment, especially if you get any complications. Many surgeons will try to use more minimally invasive surgical approaches to get their patients through. I think the argument with minimally invasive shows that they heal quickly and they don't have a bigger incision, and the medical oncologist may be able to start chemo sooner. But that's been some of the difficulty in a lot of the studies because the studies are mixed because they're open surgery and minimally invasive surgery. And if you look globally, not everyone has all the resources to do minimally invasive surgery. So one of the first randomized studies was the Synchronous study, came out in 2012. This was a German multi-center randomized trial. They had two arms. Arm one was resection of the asymptomatic primary followed by chemotherapy. The second arm was chemotherapy alone. And so they used, again, a 5-FU-based chemo with cetuximab or bevacizumab. They looked at their overall endpoint as being overall survival for their primary endpoint. And then they also looked at, as a secondary endpoint, how quickly did we have to intervene on patients who are on chemo. They did have some results. It was just though an abstract, so not really detailed results. It came out in 2022. They had difficulty achieving enough patients to get a very strong answer, so they had to combine their study with a Spanish study that also is doing a very similar regimen and process. So they had 393 patients. As you can see, the split between the two arms was almost equal, not as good as we would like in a randomized trial. But in this study, they found no difference in survival. But again, this was an abstract. There was really no discussion in the abstract as what were their limitations, the critiques, what were some of the problems that they had in this study. So though this shows no difference in survival, I'm not sure it's something to say for sure, like this is how we should go. This was another study that came out in 2021, the IPAC study. This is a Japanese multi-center trial. Again, you'll see a common theme with all of these studies. They have either surgery first, followed by chemo, or chemo only. And then you operate if they develop symptoms. This study also terminated because of two things. One, they didn't get enough patients enrolled. And two, as you can see in their Kaplan-Meier curve, they didn't see any difference in survival. And this curve was done during an interim analysis during their randomized study. And in their interim analysis, they saw zero difference. And so they felt it was just futile to continue this study. So that study ended. So this study did not seem to support doing surgery on the asymptomatic primary. There's the Kairos study. This was a Dutch study, same process, same overall endpoint. This study results are still pending. They did a 60-day mortality analysis that came out in 2021. And they found that they had 99 patients in each one of the arms. And in arm one, the treatment arm with primary tumor with chemotherapy, they had 11 deaths and 3 deaths in the other arm. They found this to be significant in looking at 60-day mortality. They were not fully advocating one way or another. They wanted to wait for the overall survival results. So that's still pending from this study. The GRECAR 8. So this is a French multi-center study. And there's a little difference in this study because here they have patients undergo chemo prior to enrollment in the study. So this is a little different. All the other studies did not give anyone chemotherapy. This study gave chemo first. After giving chemo, you were randomized to arm A or arm B. So arm A is you get after your 4 cycles of chemo, you get surgery followed by more chemo. Arm B is just you only get chemo. So they're going to look at first overall survival at 2 years, progression-free survival, quality of life. They are hoping to enroll at least 290 patients. I have not seen any results back on this. I think they've stopped enrolling. So I think they're in the process of looking at survival if they've collected enough, and hopefully in the next year or two, we might see some results from this study. And this is the schematic of how they randomize their study. Another interesting point on this trial, so from a surgical standpoint, when these patients come to us for surgery, the way they describe their study is they would use process of enhanced recovery after surgery, so ERAS. Patients would get immunotherapy before, not immunotherapy, but immune nutrition before surgery. They advocated, if possible, doing minimally invasive approach, if they could. And so they wanted to take the components of ERAS and also place that into the study because we know the components of ERAS have also been shown to have good outcomes for patients. This is another study. It's called the Climate Protégé study. It started in 2014. The results are still pending. It's a French study as well. I've not seen too many papers written on this, but they're specifically looking in patients who have unresectable liver metastasis. So here you have colectomy, followed by chemo, followed by targeted therapy. And I don't think they included rectal cancer in this. And many of the other studies may not have included rectal cancer as well. So the discussion with rectal cancer in this management of the asymptomatic primary is it gets more complicated because we all know the surgery for rectal cancer is not as quick and easy as surgery for a colon cancer. So this study has been open since 2014. I've not seen any publications or results on this yet. So when we kind of look at all of this, there's retrospective studies. There's too many out there to count. I wanted to just sort of summarize just a few of them. Most of the studies retrospectively have shown a benefit in removing the primary. So we have this problem, right? We have the randomized studies that aren't fully supporting it. And then we have retrospective studies that say there actually may be a benefit. One of the ones that I found that said no was this one paper by Alawadi et al. It came out in 2017. So they looked at the National Cancer Database in the US. So these are all Commission on Cancer hospitals that have to have, so they're certified cancer hospitals. So there's a level of quality control that takes place in this group of hospitals. So they had over 8,000 patients, but when they looked at their study, and they also did propensity score analysis, which is always important to do in a retrospective study to eliminate any bias. But here they did not see any benefit to resecting the primary. So this is a paper that I actually was the PI on at Loma Linda. So one of my residents who's now a colorectal surgeon, we worked on this paper. So we published this in 2017. We took the NCDB data, but we actually wanted to look at this larger. So we included years 2004 to 2012. We especially did that because we wanted to look at the patients that would have had much more newer advances in systemic treatment. The surgery part, would not have changed much, but we wanted to capture the systemic treatment portion of it. And in our study, when we looked at this with 65,000 patients, and both arms were almost equivalent, and we also did propensity analysis on this, we found that there was a benefit in removing the asymptomatic primary versus no surgery at all. And when we did propensity score matching, we found that our hazard ratios and odds risk also showed benefit in doing surgery on the primary. There are several other studies that have been out there. In 2015, the study from Ferrone, they looked at pooled analysis from other randomized trials. They said, yes, primary tumor resection is an independent predictor for survival. So they would advocate based on that study. Another study in 2019 looked at a meta-analysis of 72 papers, 159,000 patients. They also did as much propensity analysis. In that paper, they said that patients that had resection with 5-FU-based chemo afterwards benefited from surgery in the asymptomatic setting. So as you can see in the retrospective data, we seem to show benefit, but we know there are flaws to looking retrospectively because we as surgeons, we tend to operate on the patients that we think will do better. They tend to sometimes be healthier. They have less other medical problems. This was an interesting paper that came out in 2022. This is a Chinese paper. They also looked retrospectively, but they included a group that the other papers don't. So they look at this chemo to surgery and then potentially getting more chemo after surgery. And what they found is that these two groups, the surgery and chemo, this group here, the chemo surgery, chemo was a much smaller group, but both of these two groups did better than giving chemo only. But they also found that this smaller group of patients, this was about 40 patients compared to about 100 in each one of these. This smaller group of patients did better on propensity score matching than the other two groups. So this tells us that surgery may play a role in management of asymptomatic primary, but it depends on how we coordinate this with our oncologist. So kind of the summary of all these retrospective studies, they all show benefit in primary tumor resection, but there's inherent bias because we know that we tend to operate on people that may do better. And so you do these propensity score matching to get rid of all these confounding factors to see, does the retrospective data still hold? We also know that surgical techniques have changed. So there There are countries that are doing now more minimally invasive surgery, whether it's laparoscopic versus robotic versus open. In the United States, we do a lot more. We're trying to do more minimally invasive with laparoscopic. It's now moving more toward robotic. I think in Europe, it's probably mixed. It's probably more minimally invasive. I think in other countries around the world, it's also going to be mixed. It all depends on, does an institution have access to a robot? If you don't, can you do minimally invasive surgery with laparoscopic? Because we know that that tends to have less complications. Patients can recover quickly from those type of operation, but the tried and true is always open surgery. It's still there. In this group of patients, I think rectal cancer surgery is oftentimes less performed because of the different complications that will happen. And the other aspects of a lot of these retrospective studies is they've all been done in time, like the data that they're looking at was before we had better chemotherapy. So there are some confounding issues with that. So what are some of the take-home points that we can look at with management of the asymptomatic and symptomatic? This should be asymptomatic. The asymptomatic primary colorectal tumor is still an area, I think, of controversy because we don't have full randomized data to tell us what to do. And the retrospective data is arguable of whether you believe it or not. So we're still waiting on the 2 randomized controlled trials. The difficulty in these randomized controlled trials is just getting people enrolled in them. And we know that systemic therapies continue to change. But one thing that I would say is that systemic treatment is core to the management of this disease. Surgical approach. So minimally invasive approach is it's growing field. I don't know what the experience, and I think we can talk a little bit about this, the experience in Egypt is with minimally invasive surgery. Again, it all depends on the resources and the training, and the robot is expensive. Even in the US, it's expensive. And so some institutions will have it, some institutions will not. But I think people look at that as a way potentially in an asymptomatic patient that has unresectable metastatic disease, using a minimally invasive approach decreases complications and patients can continue with their chemotherapy. So when I look at this whole aspect, I kind of thought in my mind, how do I want to approach this as a surgeon? And so this was sort of what I came up as sort of a simple algorithm here. So, when I see a patient, whether I see them in the emergency room or I see them in the hospital and the medicine doctors are consulting and they want some, they're asking me questions, Dr. Solomon, what do we do with this patient? So in my mind, I look at this. So if they have unresectable stage 4 disease, and my first thing is let's look at this, the receptor status, because we know the type of chemotherapy is going to affect this. And so the way I look at this is if they're asymptomatic, my view would be to actually start first with some chemotherapy. And I would put them on chemotherapy, and potentially if I follow what's happening with the GREC-R8 study, you put them on some chemotherapy cycles for maybe 4 cycles, and then afterwards, after they have some chemo, plan on surgery. I think those are the patients that will end up doing the best. I think if they go on chemotherapy and they're not doing well on chemotherapy, and they still don't have any symptoms, I may or may not choose to operate on them because I might be able to take out the primary tumor, but I might not improve their survival because we're still waiting on some of the other studies to come out. So a lot of this is surgery, patient selections for surgery. And ideally, if you can utilize minimally invasive approach, use it. If not, open surgery still works. So that's my lecture. It's a shorter lecture on this topic, but it's a very complicated topic. But I wanted to at least save some time for questions or comments and, and see how we kind of manage things here versus what happens in Egypt.
Thank you, Dr. Naveen, for this wonderful presentation. We can now start taking questions from the audience. Please, if you have a question, raise your hand. Start by Dr. Medhat Khafagi. Dr. Medhat, please unmute. you have a question, raise your hand, please. Dr. Medhat, unmute. It's not working. If you have a question, please raise your hand. I have personally a question. So you recommend always. So your recommendation is like in the Chinese paper, the third smaller group. So chemotherapy, then surgery, then chemotherapy, right?
That's in my mind when I think of this. So I look at this as you have a patient that has a systemic disease problem. And so I look at this as, let's give them chemotherapy because, we've all seen it. You operate, they get a complication, they so delayed with chemo. And so my thinking is, the way I look at this more and more is that if we give them some cycles of chemo up front, and if they get a good response, then we can operate, and they're a good candidate and we can do surgery and remove the primary and then continue with chemo. That is how I would probably look at many of these patients if I have a patient with asymptomatic primary.
Okay. Dr. Medhat, you have a question?
No, thank you.
Okay. Okay, we have Dr. Mahmoud Al-Masri.
Thank you for invite. I really appreciate your effort for such a nice weekly activity. Now it seems that we are facing the same problem as a surgical oncologist with different solid tumors.
Mm-hmm.
We have the same issues when we treat the primary breast in metastatic settings. It seems similar with the colorectal cancer as well. All retrospective data showed that there is improvement in survival when you take the primary tumor out. But the other prospective trial, still they are negative with these issues. And even with the last trial in the breast cancer issues, they have a neoadjuvant systemic treatment. Start neoadjuvant, they start with the systemic treatment first, and they fail to improve survival. So it's similar in every part of the solid tumors. So how you explain this?
So when we look at breast, that's a very good question because I do breast cancer as well, and we've had a number of patients that have had metastatic disease, and we treat their metastatic disease with chemo, and then we do the mastectomy, and we do see this benefit of survival. So the thought process is that by leaving the primary, is there seeding still happening? Like on a microscopic level, are cells still spreading from the primary and continuing the whole metastatic disease process? And so by removing the primary, can we eliminate that seeding? That has been some of the thought process on breast cancer. And so I think if you extrapolate that to look at that in colon cancer, that is likely where individuals probably think by taking out the primary, you take out the source. So, you look at this as getting source control. I've not seen any translational or basic science research to see if that truly holds, but that would probably be the reasoning of why surgery on the asymptomatic primary is beneficial.
Can I add some of the situation where I'm doing just the primary as well, where you have differential response to the tumors, where the secondary primary they are responding while the primary tumor is still progressing. I recommend doing surgery. Another situation where the secondary tumor clinically they have a complete clinical response to the systemic treatment, and still there is a residual disease in the primary, and rendering the patient no evidence of disease, they claim that there is improved survival.
Yeah. No, I would agree with you on that. And I've seen the cases too, the primary gets worse, the metastatic disease is improving. It may not be still resectable, but if the primary is getting worse, I look at this as this is a potential problem for the patient. So if they're not symptomatic now, they will become, and I agree in that setting, I would operate on that patient.
Thank you. Thank you.
We have another question from Dr. Walid.
Yes, hello, good evening.
Good evening.
Hello, thanks a lot for your concise talk. I would like to ask you if you have a symptomatic patient with a resectable metastatic primary, but it is metastatic to two sites, liver and a limited pelvic peritoneal disease. So this patient is young and she is fit, and you can resect the primary. Would you go for resection of the limited pelvic peritoneal disease on the same sitting, or you would refer the patient for chemotherapy, or you would not do resection at all and just do like diversion?
So the symptoms that she's having from the primary, is it
Intestinal
obstruction?
obstruction. Yes,
Obstruction.
obstruction.
Yeah, so in the setting where there's obstruction and you have some limited peritoneal disease and you have liver disease as well, generally these patients, she's young, so generally these patients, I would still divert, give them chemotherapy, and laparoscopically, or if you do them divert laparoscopically, or you can look laparoscopically and still try to divert somehow. I would still consider this patient though, even after chemotherapy. And we've had cases like this where we will still plan on a curative intent, because we want to see, are they going to respond? Does the liver respond? Do they develop more peritoneal carcinomatosis while on chemo? Because my plan would later be to go back in and do a definitive operation where I will take the primary and whatever limited peritoneal implants are near the primary. And in that setting, if the liver resection is also reasonable, whether it comes to a different question, whether you do everything in one surgery or you stage it. I often I tend to stage a lot of my synchronous disease depending on where the primary tumor is located. So for example, if I have a tumor that's in the right colon and I'm doing a liver resection, then I'll do it all at the same time. So I'll do right hepatectomy or left hepatectomy, and then I'll do the right hemicolectomy at the same time, because I can do everything through the same incision. Minimally invasive changes, but to answer your question, in this type of patient, I would divert, give them chemo, see how they respond, but I would still, even though they have resectable metastatic disease in the peritoneum and the liver, I would still plan on going later on to resect that.
Okay, thanks a lot.
Okay, so you would start with chemotherapy and diversion, and then.
Yeah, and it's not in the sense of that patient will never have surgery. I think I look at this as a patient who we're testing obviously some levels of biology, but we want to make sure that, because I think what we sometimes will see is we do an operation and for a period of time, patients get immune suppressed. And so there can be a worsening of disease as well. So I look at systemic problems. Sometimes they need to have a systemic treatment sooner. And it doesn't mean that surgery is ever off the table. I think in that setting where they're still resectable, I think surgery is still on the table for the next step after having chemo.
Okay, we have Dr. Mahmoud Al-Masri one more time.
Yeah, thank you again. In a patient who's obstructing, will you divert or you will stent? Because there is some data now coming in the non-metastatic setting. They say that stenting have a poor outcome when you do that compared to the diverting. What do you think about this?
Yeah, so in the non-metastatic sensing, if they have a colon obstruction, I take them to surgery. So again, location also depends. If it is a rectal cancer that needs to have chemoradiation up front, then I will divert those patients. I will not put a stent, because the stent makes the operation much harder. And if it's just a splenic flexure tumor that's isolated, I go to surgery to remove it. I won't stent those patients.
No, I totally agree with you. There is some data now looking to the microenvironment of the colon cancer that being stented, as well as to the circulating DNA in those patients who being stented, and they showed there's unfavorable outcome with those. Thank you.
Yeah.
Thank you, Dr. Mahmoud. Do we have any other question? Please, if you have any other question, raise your hand. Doesn't look like we have any more questions.
well, hopefully we'll hear what these other randomized trials say, but I think, I think all of us as surgeons, we do the best that we can for our patients. And I think when we think about taking care of these patients on the patient-centered level, then we're always going to make the best decisions for them. So I think if we keep that as our focus, all this other data research helps us fine-tune that decision, but ultimately, as a surgeon talking to the patient, it's that decision that you have with them that's the best. So
Totally agree. Okay, I think we don't have any more questions, and we'd like to thank you, of course, for this wonderful talk. And certainly, if you have time later, we would definitely want to arrange more talks if you have the time for it.
yes, no, we'll be in touch. I talked to Dr. Yaqub as well, so we can kind of figure out what to do for some additional talks and any topics that you guys have as well and things that I can relate. But I know I had one question. I know one question I have out there from a surgery standpoint, what has been the experience in doing minimally invasive surgery in Egypt? Is it do you guys, do most institutions have robotic surgery or no?
We do have the robot, but let's say it was mishandled, or like it wasn't well. They didn't use it well, so it was used maybe in a bit some urological cases, but now we don't use it regularly. Like it was mishandled or something. We do have minimally invasive laparoscopic, of course, but sometimes like not everything is available. So like it all depends on if like everything is available, if all the equipment is available, all the instruments, because sometimes like there are some issues with maybe importing and stuff like that. So like when we have it, we use it. But I think the most common, of course, is the open traditional surgery.
And there's nothing wrong with open surgery. I mean, I think we all agree. I look at all of this stuff with robot and laparoscopic. These are all additional tools to accomplish the same goal. And the key is performing the resection. Whether if you have to do it open, do it open. If you have the tools and the availability to do it another way, do it. But I think as long as you keep the focus on the main goal of getting cancer out, how you approach it, you approach it in the best way that you feel comfortable doing. So
yeah, this is what matters. Yeah, resection.
So. Well, thank you so much.
Thank you, Dr. Naveen. I appreciate your presence with us tonight, and definitely looking forward to your next talk, hopefully.
Okay. All right. I'll be in touch with you. Thank you.
Okay. Thank you. And I'll be sending you the video tomorrow.
Okay. Perfect. Thank you.
From today. Okay.
Right. Thanks.
Thank you. Thank you all, and have a good night. Bye-bye.